I felt my job was to reassure my wife and to trust the professionals. So I accepted. I was told Joshua was fine. We're keeping a close eye on him. But looking back, he desperately needed to see a paediatrician and he desperately needed antibiotics. None of that happened. And this is the very difficult bit of the story. So 24 hours after Joshua was born, he collapsed. I was getting ready to collect my wife and son from the hospital, and I had a terrible phone call I'll never forget, saying, "We're very sorry to tell you Joshua is struggling with his breathing. You need to come to the hospital." When I got to the hospital, Joshua was in the special care baby unit. He was very quickly transferred for specialist care. So he was transferred to another hospital called Manchester St Mary's, and then he was flown by helicopter to the Freeman Hospital in Newcastle, where he was put on a treatment called ECMO, so extracorporeal membrane oxygenation. This was just a horrific time for us. We were expecting to take Joshua home, and suddenly we had a baby who was critically ill and really fighting for his life. Now, the next slide is the difficult bit of the story. So Joshua was born on the 27th of October. The photo in the middle is Joshua with my daughter. We're thinking everything's okay. After Joshua collapsed, he's eventually transferred to the Freeman Hospital in Newcastle. That's a photo of Joshua at the bottom there in the Freeman Hospital in Newcastle. We were initially told his prognosis was good, that we would take him home, but there was a high chance that he had some level of brain damage. Now, very sadly, after 9 days of intensive care, basically, when they were trying to wean Joshua from the ECMO machine, he developed bleeding in his left lung. That bleeding became catastrophic, and absolutely tragically, on the 5th of November 2008, Joshua died. And you can all imagine how horrendous that was for us. So really, your life turns upside down. Now, at the time, I was working as a nuclear engineer in the nuclear industry, and I was very used to a culture where a no-blame culture, a culture that was focused on learning, where it was okay to talk about things going wrong, and that the focus was always on learning. So, a rusty bolt in the wrong place would trigger an investigation, and there was never any fear or concern about that. It was always about learning. And my expectation was that the healthcare system couldn't turn back the clock. We couldn't change what happened to Joshua, but my expectation was that the healthcare system would learn from what happened. So accepting this is in a different country and quite a long time ago, I'll just give you a very brief summary of what happened next in Joshua's case. So basically, there was no inquest, so the coroner's inquest system, because the coroner said Joshua has died of a natural cause, bleeding from the lung, so we won't open an inquest. The doctor in the hospital where Joshua died said, we recommend, you must raise a complaint about what happened to Joshua, because we've got concerns about how he ended up in this condition. It shouldn't have happened. We raised we didn't view it as a complaint, but we raised concerns with the hospital where Joshua was born. And they carried out an investigation, but it was a very superficial investigation. As they were doing this, we found out that they'd lost some of Joshua's medical records. So any of his observations from the time he was born to the time he collapsed disappeared. And we sensed that the trust weren't being open and honest with us. We were told it was a one-off, that nothing like this had happened before in the hospital. And there were various investigations into what happened to Joshua. But the summary is, we were very unhappy with the hospital investigation. We felt that they were not being open and honest about what had happened to Joshua. And if I fast forward in time, this is a very well-known publication in England called the Health Service Journal. So Joshua died in 2008. And if we look at this headline, this is from the Health Service Journal in England: mothers and babies still at significant risk at Morecambe Bay. So this is February 2012, so quite a few years after Joshua died. This is the headline. So how did this headline come about? So I'll just very briefly tell you the story. So after the hospital trust did their investigation into what happened to Joshua, we were very unhappy with that. It hid things from us. It said things like, well, the records of Joshua's observations have gone missing, so we don't know what his temperatures were, but the staff all report all his observations were normal, therefore nobody is at fault. Yet my wife and I remember reading very low temperatures on his chart, so people were trying to cover up what happened. So after we went through the hospital complaint system, we went through what's called the healthcare ombudsman in England, who looked at Joshua's case and decided that they wouldn't do an investigation. They said that the regulator would make sure the trust improved. So this was becoming a battle, really. And the hospital eventually said, we're not going to speak to me anymore as a parent, that they've answered all the questions they can. So really, we felt that the whole case had closed, and we really felt that we hadn't got the truth about what happened to Joshua. At this point, I went back to the coroner, so the coronal system, and managed to persuade the coroner quite a few years later to open an inquest into what happened. So that's quite unusual in England, because the inquest normally takes place a few months after the death, but this took place a few years after, because we managed to persuade the coroner. And to cut a long story short, the inquest found 10 serious failures in Joshua's care. It was very critical of the staff, that it didn't believe the staff were open and honest. And the regulators in England attended the inquest, and they were so concerned about what happened, they went back into the unit where Joshua was born, and they did an investigation, and that investigation found significant risks to mothers and babies, so 119 significant risks to mothers and babies. And it was that investigation that led to this headline. I think this paragraph would be the big lesson. So Dr. Kirkup talked about errors occurring in every healthcare system, but what's inexcusable is the repeated failure to examine adverse events properly, to be open and honest with those who had suffered, and to learn to prevent reoccurrence. Yet he said this is what happened over the whole period of this investigation, so from 2004 to 2012. And I think certainly in England, and I think other places around the world as well, that's a real tragedy in healthcare, is things do go wrong. So error is human. Yet the real preventable bit is failing to learn from what happened. Yet there is a pattern, certainly in England, of the healthcare system not learning from what happened, and that became, after that report was published, a bit of a focus of my life. So how can we change this culture? What can we learn from the industries like the nuclear industry, where we had, give you an example. When I worked in the nuclear industry, we had a scheme where if there were a certain number of incident reports a month, 100 or more, we would pull one of them randomly out and give whoever it was an iPad as an indication that this information is really valuable and it's professional. So that culture really was very clear to me in the nuclear industry, that we must be open, we must have psychological safety. It was always viewed as just a normal professional thing to talk about problems and to learn from them. And that's something I've tried in my career to influence in healthcare. So I'm just going to talk a little bit for a moment about what good looks like. And in England, following the Morecambe Bay report, there has been quite a lot of work around what safe maternity looks like, safe maternity care looks like. And I'll just draw your attention to this report. So this is by a superb person called Mary Dixon Woods. And what they did was they looked at a very high performing maternity unit. So a unit in Bristol in England that has very, very safe outcomes. So they did an ethnological study, what it was about that unit that made it very safe. And I think it's a really great paper. And I'll just talk to you very briefly about what that paper showed. So looking at the way this team behaved, they found these 7 features, and I think these are probably true for maternity systems all around the world, not just in England. I'll just talk through them quickly. So number 1, a commitment to, let me just move the video so I can read that. So a commitment to safety and improvement at all levels with everyone involved. So technical competence, so the importance in maternity of training, and particularly multi-professional training, so midwives and doctors training together. And number 3, talked about teamwork, cooperation and positive relationships. And in Joshua's care, that was one of the things that really went wrong. It was midwives and doctors not seeing their role as the same thing. And in England, we had a problem where midwives often saw their role as keeping birth normal and natural, so keeping doctors away from the care. And it's all very well, we all want to reduce intervention in unnecessary intervention in childbirth, but not at the expense of safety. So a baby like Joshua that needed to see a doctor, we shouldn't have a situation where midwives and doctors are so working in silos and not talking to each other, where that puts safety at risk. So that's been a big lesson in England. Constant reinforcing of safe, ethical and respectful behaviours. Number 5, so multiple problem sensing systems used as a basis for action. And this idea that healthcare is complex, dynamic process. We heard about that yesterday. Very difficult to plan healthcare on paper. You know, it's so dynamic, things are changing, it's adaptive. A safe healthcare system, everybody has to see their role as a problem sensor. So we need people looking out for hazards. We need people reporting incidents, things that don't look right, and talking openly, and certainly learning when things go wrong. So big issue there. And systems and processes designed for safety. So we all hear about human factors, and for me, human factors is about designing systems and the environment to really make doing the right thing as easy as possible. And so often in healthcare, the systems and the processes make it very easy for people for people's errors to lead to harm. And we need to be designing systems and processes that make doing the right thing easy and doing the wrong thing very difficult. And 7 was about effective coordination and ability to mobilise. So things like staffing levels need to be very adaptive in maternity. Nobody can predict the flow of pregnancy and childbirth. So we need adaptive systems. So just on this theme, so I do want to talk about this organisational culture and problem sensing again, just to refer to So after the Morecambe Bay report was published, we still just to briefly share with you that I actually managed to have a meeting with one of the midwives involved in Joshua's care, and this was somebody who I felt had a lot of responsibility for what happened to Joshua, and somebody I felt quite angry towards. And after Joshua died, we weren't able to have a dialogue with the midwives. So I had a very powerful meeting, actually, that I'll just share with you briefly. And I basically met one of the midwives and was able to have a conversation with her. And the conversation went along the lines of I wanted to tell her that I didn't blame her for what happened to Joshua, but I was angry about what happened afterwards. And when I sat down and had that conversation with that midwife and turned to her and said, I want you to know I don't blame you for Joshua's death, she actually burst into tears and she said, yes, James, but I blame myself. There are so many things that I wish I'd done differently since Joshua died. For me, that was a very healing conversation, to have that conversation and to realise that the staff involved in Joshua's care very much cared about what happened. And probably the most important meeting I've had in my whole journey, actually. And I'll wrap up very quickly now. So in 2016, the Trust did publish a report into what happened to Joshua. It did a new investigation, and that report made 18 recommendations, and all of those recommendations 8 years later had been implemented. But when they looked at when, it was actually 2012, 2013 that they'd made those changes. And the Trust published this report, and it talked about the fact that had we done this investigation sooner, it could have improved outcomes for other mothers and babies. And the tragedy really with the Morecambe Bay report is 6 babies died after Joshua. So a big message for me is that missed opportunity that happened, and how it is so crucial that when these things go wrong, we learn from what happened. A slide here about compounded harm. So the way we respond to harm is so important, to do with reducing further harm. So that's a paper to look at. I encourage people to look about restorative culture. So looking at who's been hurt, what they need, and whose obligation it is. So Sydney Decker's done some great work on this. I won't share this final story, but there's a very powerful story about the missed opportunity to I'll finish there. Sorry I rushed the end of that talk a little bit, but I know we've got other speakers and we're running a little bit behind time. So just a big thank you for listening to my story, and I hope some of those themes resonate with you. So yeah, I'll stop sharing my slides. Thank you very much.
Thank you very much, James. It was a wonderful talk and I know a deeply personal story for you, but we thank you for paying it forward so others can benefit. Really appreciate you and your time.
Thank you very much.
So in the interest of time, I'll move on to our panel. I know we are significantly behind time, so I will ask, I'll just outline the format that we're going to follow. I'll ask questions of our panelists related to this overall theme of patient safety from the start. I would ask you all to limit your answers to 2 to 3 minutes. And then I would ask the chairs and co-chair to summarize. Maybe I can start off with two of my colleagues, Drs. Miraj and Dr. Haroon, because both of you lead you account for the majority of Joint Commission accredited hospitals in the country between the two of you, and are leaders in the field. So it's a multi-part question. I'd address it to both of you and ask you guys to answer. What do you think is the difference between quality and patient safety, given your experience in both? And how do you correlate this with your journeys in quality and patient safety at your respective institutions? Keeping in mind the role on the national level, you guys have been pioneers, both institutions have, between the private and the public sectors. Drs. Miraj and Haroon? Yes, sir. Well, the first part is really, what do you think is the difference between quality and patient safety, and how have your institutions' journeys reflected the same for the country?
Okay, I don't know if this is working or not. I think it is now. I need to hold it closer. So yeah, thank you for asking me to comment on this. I feel they are very interrelated and very separate at the same time. A lot of quality assurance that you do is about setting standards, benchmarking, auditing, collecting data, reviewing it. But also, all of this, when you do, and if you do it honestly and with the frame of mind, as James just said in his talk, of a problem sensing mind frame rather than a comfort seeking one. So quality assurance, if you go towards the fact where you're forming indicators where you already know you're doing very well, then you're just reassuring yourself. Those are just false pats on the back. The main thing is to be able to, in quality assurance, find problem areas, work on them and solve them. And if you move with this mindset and you're open and transparent with your data and you actually analyze it to improve outcomes, it will have an overreach into patient safety. Yes, there's a lot of components of patient safety which are independent of quality, but I think they're both interrelated in the sense that in quality, if you do it the right way, with a problem sensing mindset rather than a comfort seeking behavior where you're just trying to reassure yourself by forming indicators or doing audits on things that you know you're doing well on, or you're expecting you'll do well on. So therefore, if you find those problem areas, you plug those gaps, you have these honest conversations, and every time something goes wrong, rather than pointing or blaming individuals, you should try and look into the system. Even if there's an individual or a human error is coming to light when you're investigating a incident, my take always is that why was our system so weak that this individual could make this mistake in the system? So with that, I'll leave it to Miraj.
Yes, Dr. Miraj.
My colleague said, Haroon, believe in the phrase, every system is perfectly designed for the results it gets. Quality and patient safety go hand by hand. You can't separate them, right? And instead of using the word quality assurance, I would prefer to use the word quality improvement. And just going back on a very simple model, and that can relate you very well, I mean the audience, if you want to understand how quality and patient safety go hand by hand, just refer to the Donabedian model. Structures, processes, and outcomes. So whatever you are aiming for, from as a theme is patient safety from the start. So let's take the start in my definition, in this example, for a hospital, the start is from the patient admission and the end is from a healthy discharge. Now, throughout on the continuum of care, if you apply this model at every step on this invisible assembly line in the healthcares, you have set standards to achieve high quality, and you have made a commitment, do not harm. At every step, you are making sure that you're not harming the patient, you are following the best standards, and you are achieving the best outcomes. And you are measuring those outcomes, right? In the form of perceived outcomes, patient experience satisfaction, in the form of clinical outcomes, I mean all the clinical indicators, and of course in the form of functional indicators. So this beautiful small narration reflects very well, and I hope that answers your question.
Absolutely, sir. Thank you. Maybe I'll move to Dr. Tariq in his capacity as president of the Pakistan Society of Family Physicians, and ask about what do you think needs to be done to move patient safety forward at the individual provider or the professional society level to really improve our patient safety, either focus or clinical outcomes, which is our ultimate goal.
Bismillahirrahmanirrahim. Actually, you see, the government is not paying attention to the primary care in Pakistan. The people who have done their graduation 20 or 30 years ago, they are still not having any continuing medical education, and there is no enhancement in their knowledge. So I think that the things which were present 20 years ago, for example, antihypertensive, the beta blockers were on the top, but now they are on the bottom. So I think the continuing medical education is the must. I'll just quote an example that in 2010, there was a famous hospital in Lahore from where the Healthcare Commission started. So there was a PG. There was a small child over there, and she was having some temperature, fever. So and she was crying. So the parents said that give her some medicine. So he just have done a lot of work over the metabolic diseases because yesterday there was a presentation in which William Osler's quote was announced, and he said that one of the prime duty of a physician is not to prescribe medicine. So I think we must give emphasis on primary prevention. And you see, at the metabolic diseases, we have seen a lot of good result by just changing their diet. And you see, our youth sitting over here, we have seen that in last CME, there was a 19-year girl having MI. So when the history was traced, there was no family history. Just she was having this fast food throughout the day. And late night, she was not sleeping early in the night, and she was awaking whole night. So I think we must change. We must work on this preventive aspects. And you see, and the latest knowledge, that is the only way that we can prevent the untoward effects in medical field. Thank you.
Sir, and you mentioned as if government won't step up, I'm glad to see that our professional societies are stepping up. I'm going to shift gears and move to one of our one guests, Dr. Brofko. and I know that you work in clinical technology, and clinical informatics. My question is more about what role do you think technology can play in improving patient safety in low resource country settings? And what sort of there's plenty of current advancements out there with generative AI, predictive modeling, all that. But which of these current advancements do you think might be applicable to frontline providers in places like rural Pakistan, where a family practitioner is sitting miles from any secondary care center, barely has internet, and is caring for many, many patients?
Yes, thank you very much and good morning. First of all, patient safety has several aspects, of course, and two, in my view, most important of them are medical errors, and second is safety and efficiency of your services. And this Joshua's story falls into this second category, which is about safety and efficiency of their local services. But I'll start with the first. So medical errors. Medical errors happen everywhere, as we know, and there are different categories of medical errors. For example, in the US, they define events when a surgery happens on the wrong patient, for example, or your dentist removes a wrong tooth. So they call them never events. So of course, the never events also happen everywhere. So you simply should have a simple processes in place to avoid those never events. They're called never events because they should never really happen. However, errors still happen. Most of those medical errors are smaller, a lot smaller. Wrong dose, wrong treatment, wrong drug. So the system should have a process in place, a culture, medical culture, to capture those errors, because errors are never really individual. Errors are mostly system specific. So it's all about the system, what we've got here locally. So we, as clinicians, should be able to recognize this and say, yes, medical errors happen, and we should have a system in place to record those errors, to analyze them, to learn from them, and also, and then using this learning to improve services. I can give you an example. In several countries, we've implemented hemovigilance systems. It's about medical errors during blood transfusion. Blood transfusion is a huge area where errors or near misses happen very often, and they can be deadly, of course, as you know. So having a system in place, hemovigilance, they call them hemovigilance systems, simply for hospitals to record those errors. Yes, the error happened, wrong blood or expired dose or something, or near miss. So you record this error and report it, and simply do your own internal investigation without blaming anyone. However, you learn from this, and at a national level, you see the national picture and you see the trends, and you can improve this service at a national level. So having a hemovigilance system in place will improve service. So that's about medical errors. And second aspect is about safety and efficiency of clinical services. And for most clinical services, you can define quality indicators. You can define quality indicators for surgery, for example, for different types of surgeries. For most of the surgeries, that will be patient survival, surgical adverse events, in-hospital mortality, long-term mortality. You can define for every type of surgery. You can define clinical indicators. For cancers, for oncology, and for other services, so clinical quality indicators can be service specific, which define your efficiency of the service, such as time from diagnosis to treatment in cancer, for example, or time from myocardial infarction to patient admission. So you can define time, and time is often what defines patient survival or death. So it is important to start with this. So as long as you can define your quality indicators for services, then you can measure them. Because if you measure them, you do better. Research shows that if you do not measure what you do not improve. If you measure, you simply improve by definition. And technology, of course, can help you with that. And this is the main objective of the registries. Registries are implemented across all countries and services, you know, and the main objective of those registries is to help you to see the picture of your services, what's happening, to see the trends, to identify opportunities, to identify centers of excellence where you can learn from, but also to flag services such as this hospital where Joshua died. So if you have a process in place and registry in place, if you had the registry in place at that time, it would flag that service immediately, and you would be able to, without additional national investigation, you should be able to flag it and improve it quickly. Thank you.
Thank you. I'm sure technology will make it easier to measure. Hopefully, it can make people start collecting and entering the data accurately also. For our last panelist, Dr. Sehval, I actually have a more complicated question for you. This is our 9th International ICPS, and I know you've attended most of them. So there's been significant investments in patient safety across the world, including in LMICs and in middle income
This is a private and a foundation group. So no support from the government. In Middle East area, usually, we have this opportunity, or I don't know, maybe disadvantage sometimes. Anyway, without any support, a university with, many faculties, 25 students, 10 hospitals, 15 dialysis center, clinical hotels, schools, so on and so forth. So at national level also, I contributed to my colleagues in Turkey. So Turkey now, we are doing medical tourism. We have advanced healthcare. We have medical cities. Already shared with you that we have HIMSS 7, HIMSS 7 hospital, almost 10. All digitalized healthcare system. And just, overall in the country, we are receiving last year 2 million international patients in my system, the healthcare group. We are doing liver transplantation, heart transplantation, renal transplantation for the patients in Europe, Middle East, Central Asian republics. So, and my founder always tell that he is a well-known transplant surgeon, always tell that this is because of patient safety and because of quality. So if you really believe it, and one of my colleagues also shared that if you make this your routine, if you integrate this into your daily life, okay, so I think you will get success. And I'm not so pessimistic. So I'm sure that, and I also involve the Saudi Arabia and Jordan and other countries in the Middle East, Central Asian republics. I was very lucky to develop their national accreditation and quality system. Look at now, Azerbaijan now doing is really great. When I first visited the hospital, I felt myself that I went 50 years back. But now when I visited Baku, Baku is now a European city and with advanced high-tech technology hospital, same as also in Turkey. Maybe Turkey was doing better than that, but the Central Asian republics, just after Soviet Union, really, they were not doing well, but they focused also on patient safety, quality, technology. But I think we should be careful also on technology, because now we are using too much AI, all digital system, but still we need patient safety. So now it's more complex. I think we need to move that area, and we need to make our healthcare facilities more safer when regarding technology, because the technology has many advantages, made our system faster and easy. However, we are sometimes ignoring the safety issues, data security, for instance. I'm working for the European Union. We are so much focused on data security issues, the GDPR, so on. So this kind of patient confidentiality is very important. And that with robotic surgeries, with robotic issues, digitalized health information system, we are not focusing on this issue. Maybe we should now move that area, because, time is flying.
Yes.
Really, time is flying. So I think we are doing in Pakistan also. Yesterday, I also shared with you that I review the research and the poster or presentation, and I do this every year, or last 8 years or 7 years. I do this every year, and I'm very much impressed with the efforts that your students doing, your healthcare professional doing. And I also, noticed that you also trying to integrate it in your curriculum, your education system, which is very important. Okay. I'm also working with Turkey and Saudi Arabia to integrate all patient safety issues into our curriculum, medical education, which is for sustainability of patient safety, as you asked me. If we want more success in the near future, I think as an academic also, we need to focus on this issue. So you are doing also very good, and you have manpower is much more important than everything. So I think the most important issue is to keep our young generation in our countries. Same problem also in Turkey. So we need to keep that young brain in our countries. Thank you very much.
I'm glad to see that you share this optimism that we are moving forward, and we're not that far behind from where our target is. There is light at the end of the tunnel. I'm going to hand off the session to our chair and co-chair, to Dr. Arshad Kemkhani and Dr. Asadullah Khan, for their closing summaries and statements. Thank you very much.
Bismillah ar-Rahman ar-Rahim. My first observation on the patient safety from the start is that this is a kind of say patient safety from the start. In the start, there is nobody a patient. It's a human being. So inherently, they are healthy. So once we make them the patient, then that's not the start. That's at the middle of the journey. So I believe that we should start from healthy people and making sure that they stay healthy. Last night I was addressing here, and I said that we should have a lifestyle as the first thing to really change this pattern and break this pattern. So that's my first observation, that we need to start from healthy people and making sure that they are healthy and making sure that they stay out of the hospitals. That's the safest way of caring about our patients. The first thing. Second is, of course, education. And I'm not talking about doctors or medical education. I'm talking about higher education. We have to make sure that we understand, the whole community and the whole population, they understand what is their responsibility in making sure that we stay out of the hospitals. And that includes the mothers, that includes the teachers. The way we cook, the way we use plastics enough. So all this is actually creating havoc with the population health, public health, and then we expect the doctors and the hospitals to don't even make a single mistake. And I was saying yesterday, I'm an engineer, and I believe that doctors are too tough on themselves, and they try to play God and make sure that everything. So we have to kind of broaden the net and ensure that we trap disease early and make sure that people stay safe. Then also the design, and not only the process design, but actually the hospital design. So the care starts from the hospital design, the way it is designed, the way the patient floors are designed, the way very simple things, just ventilation. We can stop infection from propagating in the hospital just by having adequate ventilation. With the hospitals which are covered with glass and with a lot of air conditioning, it's very difficult to control infection. So we have to design hospitals which include nature, which includes fresh air, which includes sunlight, which includes so all this starts from the design. So when we say patient from the start, patient safety from the start, it means really the start. And that's my take on it. Other than that, when actually a patient is there and it's 2 a.m. in the night, and there is just one doctor attending 10 patients, then whatever the errors can be managed. A lot of technical people, I think that they're much more knowledgeable than me. I believe that, I can't add anything onto that. But I think that we need to really start patient safety from the start. Thank you.
Thank you very much. तो आई थिंक ज़्यादातर टेक्निकल बातें आपने सारे ही माहिरीन से सुन ली हैं, स्टार्टिंग विद जेम्स जोशुआ स्टोरी एंड my colleagues on my right side, on my left side, they properly put it well. Quality assurance, patient safety, how interrelated they are, किस तरह patient safety by design approach को adopt करने की ज़रूरत है. और बड़ी अच्छी बात की असद भाई ने, what he said, मरीजों का महफूज रहने का एक ही तरीका है कि वो डॉक्टरों से दूर रहें. वरना डॉक्टरों ने, अस्पतालों ने उनको नहीं छोड़ना, किसी न किसी किस्म की कोई चीज तोहफा दे के उनको भेजना है. दूसरा एक बात मैं और हमेशा कहता हूं अपनी वजारत सेहत में भी और अदरवाइज भी, कि पेशेंट सेंट्रिक पॉलिसीज अडॉप्ट करने की जरूरत है. हेल्थ केयर की दुनिया का काबा पेशेंट को होना चाहिए. इट्स नॉट द डॉक्टर्स, इट्स नॉट द हॉस्पिटल्स, इट्स नॉट द डिजाइन्स, और कोई चीज नहीं होनी चाहिए. जब आप मरकज से हट जाते हैं तो फिर आप मरकज को भूल जाते हैं. और ये जो नौजवान बच्चियां बैठे हुए हैं, मेरी उनसे खासतौर पर रिक्वेस्ट होगी, बिलीव विद योर ओन आईज, अपनी आंखों से देखना सीखो. सामने स्क्रीन पे देखिए, सिवाय मेरे और हारून के, मैंने व्हाइट वास्केट पहनी हुई है, हारून ने व्हाइट ट्राउजर पहना हुआ, इसके अलावा सब कुछ हरा हरा दिखाई दे रहा है आपको, विच इज नॉट द फैक्ट. which is not the facts. Don't go with the optics. Think with your own eyes. See you with your own eyes. अपनी आंखों से देखना सीखें. और जो सबसे बड़ा जो डिस्ट्रैक्शन है with the again this 4-inch screen टेक्नोलॉजी, कि वो जो कल भी मैंने कुछ स्टोरी सुनाई थी यहीं बात करते हुए कि ऑपरेशन करते हुए भी, गाड़ी को सिग्नल पे रोकते हुए भी, सब हमारे नौजवान हर उम्र के बच्चे बच्चियां, 60 साल के बच्चे भी और 20 साल के बच्चे भी, वो सब इसी पे डिस्ट्रैक्ट हो रहे होते हैं. ऑपरेशन थिएटर एक तरफ चल रहा है, वो नर्स साहिबा जो है टिकटॉक दूसरी तरफ देख रही होती हैं. और वो जो कंपटीशन बताया था मैंने, सी सेक्शन कंपटीशन भी यहीं हुआ था, इसी शहर में हुआ था. बट सी द फ्लिप साइड, इसी 4 इंच की स्क्रीन को अगर डॉक्टर जकी या शफीक या और जो हमारे दोस्त बैठे हुए हैं, ये मिलकर इसके अंदर एक पेशेंट सेफ्टी एआई बोर्ड बना दें. जब ओटी में आप जाएं, डॉक्टर्स या उनकी टीम जाए, तो पूछ ले आपसे कि आपने मरीज को सही शनाख्त कर लिया है, डू यू नो व्हाट एग्जैक्ट प्रोसीजर इज गोइंग ऑन. उसके बाद क्या आपके पास ओटी सही हालत में तैयार है, 1 2 3 4 5 6 प्री रिक्विजिट्स या टूल बॉक्स या दवाइयां मौजूद हैं. थर्ड, जो प्रोसीजर हम करने जा रहे हैं, क्या उसके 1 2 3 4 5 नेक्स्ट स्टेप्स ये होंगे, ताकि सब के सब बिल्कुल ईद की नमाज की तरह जितना तरीका बताया जाता है, मौलवी साहब तरीका बताते हैं, यू शुड बी ऑन द सेम पेज. क्या वजह है कि एविएशन में जहाज जो सबसे ज्यादा वल्नरेबल होने चाहिए, सबसे कम एक्सीडेंट होते हैं. एवरी फ्लाइट दे टेल द सेम स्टोरीज, सेफ्टी के सारे मेजर्स बताते हैं, लेकिन हमारे जो मेडिकल स्टाफ खासतौर पे वो बातें करते करते ही सारे काम कर लेते हैं, स्क्रीन पर देखते देखते ही. तो इट्स नॉट ओनली द गवर्नमेंट विल डू, गवर्नमेंट को रेगुलेशंस बनाने चाहिए, बना भी रही है, काम भी कर रही है. बट इट्स अ लॉन्ग जर्नी. जो हमसे डेवलप्ड वर्ल्ड है वो इस पर कई दफा काम कर चुके हैं, बट स्टिल लॉन्ग जर्नी आई मस्ट से. बट वी एज द प्रोफेशनल वी टेक द रिस्पॉन्सिबिलिटी एंड जस्ट विद द बेसिक थिंग्स. आप देखिए वो सारे लोग जो रात के टाइम 1 2 3 4 5 टास्क फॉर टुमारो तय कर लेते हैं, दे परफॉर्म बेटर, दे डू लेस एरर्स. तो यही हमने करना है. वी नीड टू गो विद द बेसिक्स, नॉट वेरी डिफरेंट. बाकी अगर हम सारा सिस्टम को ही रोते रहेंगे, सरकार को, अस्पतालों की इंतजामिया को, और ये जो जकी भाई जैसे लोग जो बैठे हुए हैं ये पेशेंट सेफ्टी का गाना गाते हुए थकते ही नहीं है, तो बस मैं यही कहूंगा कि तू मरीज है, इश्क है, दर्द समझ, दवा समझ अपने दिलबर को या डॉक्टर जकी को. बाकी मर्ज जाने, दवा जाने, शिफा जाने, खुदा जाने. थैंक यू.
Thank you all very much. Thank you to esteemed panelists. If you could gather in the middle for a photograph. डॉक्टर मिराज, अगर एक शेर भी आप सुनाना चाहते हैं सुना सकते हैं. सर, आपके शेर की हमेशा टाइम होता है.
Thank you. Thank you, sir, for a wonderful job of moderating. It's always very difficult to moderate and then manage time. Now that responsibility is on me,
So I have swiftly moved to my session, and I would want my chair, co-chair, panelists. So we have the chair. Shahid Saab, please, if you can take the middle seat. Shafiq Saab, you are the co-chair. And I'm going to invite Dr. Maria Amir. Please, if you can join us. Dr. Asad Latif, please, if you can join us. Dr. Umar Awab Khan, please join us. And Shahram and Peter are online. So with this, we move to this session, which is again a mix of leadership, technology, and quality and patient safety. And when I was introducing Peter Lackman yesterday, uh, I talked about his visit to Pakistan a couple of months ago when we had originally planned the patient safety conference. For reasons we had to postpone, which were beyond our control. But Peter did come to Pakistan, and we had some very fascinating sessions on leadership and quality and patient safety. And I work with Peter on that area as well in healthcare leadership. So we will have Peter's talk, and then we also have Dr. Shahram, who is an expert on digital health maturity, and he delivered a wonderful talk day before yesterday, connecting EMR and digital health and patient safety. So he will be there as a panelist. He will contribute as a panelist. We have one talk, and then we have discussions. Inshallah, we will try to recover the time. Inshallah. So we immediately move to Peter's talk. Dr. Peter Lackman, over to you. Peter, can you unmute yourself, please? You need to unmute.
Okay. Okay, can you see the screen?
Yeah, the slides are working. Perfect. Please.
Okay. So thanks for asking me back after last night, and I'm very pleased. line, I want surgical site infections, or I want wrong site surgery, or I want, they're going to say, I want the perfect operation. I want to have good relations with the people I call patients, the why. I want job satisfaction, the why. So this is the important thing. But the moral imperative is because it's the right thing to do. The right thing to do. It's a moral imperative, and we have to really link this up. And in many different ways, you can do that. And in African culture, there's the Ubuntu, which is very important. The Ubuntu of how to do. So I've got to move on. Because then now, once you work out the why, you have to say, what do we have to do? So I've kind of condensed the previous talk. Zaki asked me, are you going to talk about leadership? I said, yeah, I'm going to tell the leaders what they must do and how they must do it. So first they must establish the big why. Why are they leaders? Why are they in healthcare? What is that why? And then you go on to, okay, this is what we need to do. The first one is you've got to create this culture of safety. And this comes from Jim Reason of the 5 pillars of culture. You have to create the culture of safety as a leader. If you don't pay attention to it, it's not going to happen. And so this is about justice, informed, flexibility, as it has changing, a reporting culture, and very important, a learning culture. A learning culture so it can be done. So these are the 5 pillars of a safe culture. And you have to do this. You have to do it, and within that is psychological safety. The next thing, safety doesn't just happen. So you as a leader have to plan for safety. That means you have to study the epidemiology and the measurement of patient safety. You have to have the leadership and culture I've spoken about. Then you have to have theories and methods that you can use. And finally, you have to use improvement science and implementation science. So this comes from Duran, the idea that you have to plan. You have to have measurements, and then you improve. But you have to know these things. And this is based on work done in the maternity in England by Liberati. I've just adapted the thoughts to come forward. Underlying all of this is you've got to have values for safety. I've put a few values here that a leader must have. Leaders must have courage. They must respect and hope. They must really be transparent. They must show what's going on. And this is where leaders are really talking about safety all the time and ensuring that safety is what they do, not what they do in response to an adverse event, but it's what they do. They're talking and breathing about patient safety, and that's part of their values. And then the last one, I think here, or there might be 2 more, is you've got to educate for safety. So this is where I'm now speaking to those in the medical school colleges and the nursing colleges and those who speak in the college of medicine I attended, is that it's got to make learning as part of continual improvement and lead to competence in psychological safety, and there must be culture. And we inserting within the healthcare worker in their genome, we are inserting patient safety, and Paul Barak alluded to this yesterday. So educate for safety. It doesn't just happen, and you've got to start this early on. We started far too late in educating people for patient safety. We just assume that if you become a doctor or a nurse, you're going to be safe. That's what I was told. But it's not, doesn't happen. We've got to educate for safety. No other industry will send a pilot, so don't go fly planes. I've been in a simulator and learning about human factors. You can't send a surgeon or any member of operating team into the operating room unless that team has worked together in a simulator, unless that team has worked together on human factors, unless that team is constantly learning about human factors. Same for an intensive care, same for an ED, same for a clinic in the community. So we've really got to educate for safety. And then the last one, of course, is how. How must leaders, how must they be safe? So I'll tell you what you have to do, now how must you do it? And here are some of the hows. The first one, you have to introduce a safety management system. And I base this on the work from Charles Vincent and Alberti. You've got to constantly build resilience by studying what you do well, because good enough, you do that most of the time. And in real time, you're studying past harm and learning from the past harm. And that's so important that you do that. You learn from the past harm, because that will help you go. And the resilience and the past harm are good. You're not looking only at adverse events. You're looking at things that work really well. And then you have to build reliable systems. Paul spoke about this yesterday. You have to know how to build reliable systems, and you have to look at what's going on, and that's sensitive to operations. And finally, you have to predict proactive safety, not reactive safety, and finally learning. So this is a safety management system that every hospital and clinical team building upwards. The SAFE program I run in the UK and in Ireland and around the world is building blocks of clinical teams using this safety management system. So safety is not something that they do when things go wrong. Safety is what they do. It becomes part of their genome. The next one, number 2, is you need to use human factors. The WHO is going to come out very shortly with a document on human factors based a lot on this model called the SEEPS model, where it's understanding what the work system does and understanding the processes and outcomes. And so that's what you really have to do. And then building on the work I've done with Chris van Hecht on the multi-dimensional model, you have to develop this moment of truth where everything's happening in safe and high quality care. So you'll have external and internal contexts. You want compassion, kindness, dignity, partnership. You want care pathways that are fundamental, that people are following. You want the pillars of quality, of which safety is one. You want the values of transparency, communication, leadership, and resilience, and all must
in our healthcare facilities? Thank you. Please go ahead. Unmute yourself, please.
Yes, thank you. Am I audible to you?
Yes, we can hear you.
Okay, great. Thank you so much for providing this opportunity. So let's just jump into the question and try my best to provide answers. Before giving the answer, let me start with the patient safety itself. I had a chance to hear the experts in the previous session when James was talking about the experience and sharing the challenges that the investigators, the challenges who faced, unfortunately, these kind of errors and lost someone, and also the challenge that the government is facing when they are going through those incidents. He was saying that we need to promote the openness when something goes wrong. He was saying that we need to involve the patient in the care, and also we need to have a complete set of records, medical records, to whenever it's needed to reflect the reality. And also we need to start on time, at the time that something goes wrong, and start immediately. And then and at the end, it was a fact that there is no individual fault; it's a system fault. So we need to investigate that fault. With this introductory and highlighting these points, let me say that over the decades, the technology is trying to address this by providing the right information to the right person at the right time. This is a very simple definition of how technology evolves and how technology might be useful, and why it's important, because it will enable the safer ordering, safer administration, safer monitoring, escalation issues if there is anything, and also registry-based improvement. But the main question is technology enough alone? Yes, of course, it's necessary. It's a must. It has to be there to let us have access and get access to the right information at the right time, and to integrate everything. But something is missing. There is a huge gap, because as one other colleague was mentioning also in the previous session, when we are not measuring the quality, we cannot see improvements. So in order to measure the quality, we need to go and go through a process that we are able to validate the improvement, to validate the technology that has been implemented, despite of all the investment that went on. So in two sentences, the technology will provide the digital records, but this is the maturity that proves the progress, that gives us a reason, that gives us measures that where we are standing right now, and where we need to head to, where we need to go, and in which place we need to put more investigations, more investments, more effort to highlight, and where we need to actually provide the proof that, oh, okay, we've already done. Let's move to the next step. Over to you. I hope I was able to provide the answer.
Summarizing your, I would say, an hour's talk, that really helps us to create a context. I will go to my other panelist, and Dr. Maria, and I'm going to build on the presentation of Peter, actually. So Peter mentioned, the role of epidemiology and measurement for patient safety. And since you work in registries and developing national registries, how does that connect with patient safety?
Right. Can you hear me? Right. Okay. So first of all, I have to admire Peter, really philosophical opening. So that actually set the right start. Why? Okay. have to add technology in your work. Patient safety, there are two different perspectives. Technology, in clinical setting, epidemiology is again, we had a discussion yesterday, it's mainly for the population. Now, there are two different outcomes. I mean, if you really, using technology for the patient safety, that should fix the errors, identify the errors, be proactive, right? Identify the initial problems early. And one important thing somebody has mentioned about involving patient. Yeah, doctor, just previous conversation. That part we usually miss out, empowering patient. So how many of you, if I ask you, how many of you guys involve patient in decision making? How many of you tell the patient they come, okay, what treatment you need? What are your preference? So that is also missing, right? Right.
Thank you very
Thank
much.
you.
Thank you. Dr. Umar, I would like to, again, linking the question with Peter's talk. Peter mentioned culture and values and healthcare professional well-being. So you're a clinician, you're a CEO, you run a hospital system. So how do you develop a culture? How do you manage your values? And how do you keep the patients safe, but also keep the healthcare professionals, safe?
Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Zaki. I think the same two questions are embedded in this statement. Why and how? So why our values, why our culture, why patient safety, and how to implement it. that while we are doing our professional work, while we are taking a history examination, we are finding spleen, investigating, helping the patient, treating the patient, we are actually doing a very, very big ibadah. This profession can become our Jannah,
Right.
or
Otherwise.
Auzubillah, the otherwise as well. So that's what I think. So if we can inculcate these values, our leaders can inculcate these values in their team, believe me, patient safety implementation will not remain difficult.
Inshallah.
Inshallah. Thank you.
So, and I deliberately asked you this question, again, building on what Peter said, and what you have actually added is that perhaps is another larger ideological purpose, the purpose of our existence as a human being. I think you've created that
I think this is the fundamental issue of why we might not be moving forward as much as we can, right? Because ultimately, the why can be answered, but we struggle with the how. Everybody goes into healthcare to help patients. That is a starting goal. And we are taught how to diagnose issues and what the treatment for them will be. The problem is we don't think enough systematically about how to implement that diagnosis. So, for example, a simple medical error, the technique calls it medical error, is hypertension. A patient comes to you with hypertension, you diagnose it. They have diabetes, also diagnose that. और आप technology can help with. This is something that other industry learning can help with. How do you implement your plans? And this requires a lot of work. What works at Johns Hopkins might not work here. And unfortunately, these variabilities in practice and application, the number one reason is communication. Number two is leadership involvement. And number three is probably pragmatic issues. दवाई है कि नहीं है, follow कर सकते हैं. And a surprising large amount of this is beliefs and practices कि मेरा नहीं ख्याल इस दवाई से फर्क पड़ता, right? So these are all safety issues, and we need to focus more on what are the implementation challenges in our settings. Is it primarily a communication issue? Is it primarily a logistic issue? Is it primarily a belief practice issue? And this differs between cities. Lahore, Karachi ke culture mein fark hai. Between institutions within the same city, we have we have civil hospital, Tao. even within campuses. Dow का civil hospital में implementation versus Dow के ओजा campus के बीच implementation में फर्क है. So implementation is something that we often take for granted. And I think we need to approach it as a scientific field and principle, and where we can learn from engineering and other colleagues. And this is something that we're starting to focus on in the field of patient safety at our center. What are the implementation challenges in our areas? And so that we can better overcome them. Because if it's primarily a belief issue, मेरे ख्याल में इसका फायदा क्या है? That's a separate set of skills you need to address that. Or it is a pragmatic issue. मुझे दवाइयाँ afford नहीं कर सकता. That's a separate set of issues. So I think we need a little bit more information and focus in the next decade on this.
Yeah. So what we learned here is that Umar emphasized on the significance of having a double-layered why, right? And Asad said that there are a lot of people whose whys are sorted, but they don't know how to implement. Slide the house of trust before I ask the co-chair and the chair. But I think that's a brilliant slide which will help us to summarize the session. The house of trust slide, please. Yeah, and while you are putting that up, I will now come to my co-chair, who's a very important person today, actually, for reasons which we will disclose in the next session, inshallah. So, Dr. Shafiq, as the co-chair, you have listened, you've heard comments on technology. Shahram and Dr. Maria, they have talked about technology, EMR, digital health maturity. These are tools which allow us to implement what Umar said, the right intent. So, and again, I just wanted to bring this into the context and then over to you. What's your take? How do you, assemble all of that?
Thank you very much. I think it was a very informative discussion covering a broad range of areas. So I'll quickly recap what I gathered of the salient features in Peter's talk. It just reminded me of Simon Sinek and starting with the why. And I think that resonated the cricket competitions, so taking the analogy of cricket, which is what most youngsters here would understand, is it's a long game. It's a test match. It's not a 2020. It's going to take time. And again, unfortunately, looking at the Pakistan cricket team, it needs consistency. You can't have a one-off wonder. It has to be done very consistently. And that's how you, over a period of time, are able to build up a culture which is ultimately definitely going to move the needle. The other point I also want to add, and this relates to what was said earlier in terms of primary healthcare and family physicians, is when we look at healthcare, we need to look at healthcare in the larger context across Pakistan, across primary, secondary, and tertiary, across government, not-for-profits, private sector, all of them together form healthcare. So looking at things like technology adoption, it's a very small fraction of those healthcare providers that have adopted technology in the first place. What to talk of their relevance to quality and patient safety. So I think it was a very important talk. It highlighted a lot of important areas that we need to keep talking about and keep working on. And I'm very optimistic going forward. We have an abundance of challenges, but that also means that we have an abundance of opportunities. Those are challenges that are very much solvable, and the results are going to be dramatic. It's going to have a drastic impact on the kind
academia, healthcare services, and industry. So, you are blessed and privileged to have enjoyed that position. So, your perspective from the leadership, which is the core, topic of this session, and how do you manage this challenge of, maintaining a culture, a just culture, again, managing the wellness of your team, professionals, deliver the outcomes, implement the systems and processes, and again, judiciously and efficiently utilize technology. So obviously the leader has to, take care of all of those things together. So if you can, give us your take from that perspective, and then the top, down approach, if I may. So please, over to you as the chair.
Thank you, Dr. Zaki. First of all, let me thank the presenters. Both of them did a fantastic job highlighting various areas that are important for
And we have, yeah, so, thank you for clapping for our panelists and our speakers. I believe that we had a good conversation. I think we created a dialogue, and I'm sure that unfortunately, time does not permit us for interactive conversation. And I, even as a chair of this conference, I struggle. How do we create that opportunity? Because again, being realistic, we don't have time, and then we try to uh, squeeze and bring as many speakers and topics. So what we do is we do that offline. So we'll go for lunch, inshallah, and then we'll have this conversation. Alhamdulillah, we have reclaimed 10 minutes. So this session was less than an hour, but very powerful, very impactful. I want to, as I mentioned, that Dr. Shafiq here is an important person today. He's always important, but today is more important. But I just had a thought that this baton should be discussed. So Shahid Saab is sitting here, Zahid Saab to samne baithe hain. So Alhamdulillah, our existing host will be able to give the baton to our next host. So I want to announce that Dr. Shafiq Sahab jo hai, has offered that he would like to host and organize the next 10th ICPS at Rahman Medical Institute in Peshawar. So although I wanted to announce that in the last session, but then I just had a thought, Kiji, the existing host giving the baton to the future host. I think that's a very good thought, and we are very, very grateful to all our hosts. So we now come to the end. We go to lunch. I'll just few announcements. Again, in the interest of time for all of us, we will try to be as quick as possible. It's 2:05. Please have lunch and be back in 30 minutes so that we can again reclaim the lost time which we had and have the last, but perhaps the most important session, which a brilliant moderator will be taking care of, inshallah. So let's go for lunch. We are back in 30 minutes, inshallah, and we will have a group picture. I would request our future leaders. So Lubna is here, Abir is here. Bigger Sahab, aap future to leader nahi aap hai, lekin I want you please on the stage. And Bashir Sahab, you on the stage for us for the group picture, please. Afifa, आप भी आ सकती हैं. आपके उस्ताद साहब जो हैं वहाँ पे मौजूद हैं. Fawzia, please. Please, आइए. And we'll have a group picture for our speakers. And Aisha, you too. Please. Thank you very much. And, all of you can, proceed for lunch in the interest of time. Thank you very much. Assalamu alaikum. Thank you very much.
Okay, goodbye, everyone.
It was great meeting you, Peter.
Yeah, nice to meet you, Oman. Where are you based?
Oman, right now.
Oman?
Oman, yes.
Oh, I hope it's safe.
Thank you so much. Considering the situation of the regional situation.
Yeah, it's one of the reasons. One of the reasons I'm not in Pakistan now is because of the flying.
That's the reason.
Yeah, just I came in by. I hope no one can hear us there.
Riphah Medical City
is
going to provide.
But anyway, I was
healthcare ecosystem in Twin Cities, and more specifically, it is going to be the first healthcare REIT in South Asia. So through REIT, we are linking healthcare sector with the regulated financial market.
फ्रंट साइड पे पोडियम लेवल तक हमने 6th फ्लोर तक अपना फ्रेम स्ट्रक्चर कंप्लीट करना था, वो भी आप देख सकते हैं अल्हम्दुलिल्लाह कंप्लीट हो चुका है। रेड साइड पे हम 3rd फ्लोर पे पहुंच गए हैं और हम प्लान कर रहे हैं इंशाल्लाह कि नेक्स्ट क्वार्टर में भी जो हमारे माइलस्टोन है फ्रेम स्ट्रक्चर को अप टू 17th फ्लोर हमने कंप्लीट करना है।
The idea is to create a space that has some kind of other program facilities like a commercial area. We will have some hotel facilities. Yes. We will have as well some congress area in order to, but because we want to create synergies and of course with the educational part. So because the best way to train is when you are close to the hospital and you want to educate the students regarding that. So this will allow us to create a more healing space.
Riphah Medical City represents the vertical expansion of our healthcare ecosystem, integrating advanced medical care, research, education, and people-centered excellence. From the designing of the world-class clinical zoning right down to the patient rooms, we are trying to ensure that the building is part of the care plan offered for your loved ones.
For the first time in Pakistan, Riphah brings an integrated medical city concept, which brings together cutting-edge modern infrastructure, advanced medical technology, and highly trained healthcare professionals. Available to both national and international patients, RMC is being designed to provide high-quality treatment at internationally competitive costs. Strategically located and connected to the region, Pakistan is an emerging destination for healthcare and wellness. RMC aims to provide world-class care rooted in values.
Riphah Medical City is not just a project. It is the continuation of a legacy built on education, healthcare, and service to humanity. A vision that will serve generations to come. The patient safety journey of Riphah started 9 years ago. It is our commitment to serve our patients with compassion in a safe environment. We are also committed to promote patient safety by working with the government of Pakistan and regulatory bodies to improve the regulatory framework for healthcare institutions. We are also building the capacity of healthcare institutions in Pakistan through International Conference on Patient Safety and through institutional collaborations.